Hey everybody, thanks for logging on here today. We're just going to wait about 2 more minutes, letting stragglers into the meeting here. So we'll get rolling here in just a second. You can enjoy these nice photos of crashing skiers and snowboarders until then.
Yep, and everybody who's on right now, feel free to submit your questions to the chat box or the Q&A button on the bottom there. And we're going to go through those at the end of the presentation and try and get to everybody's questions. If there happen to be a lot of questions, we will answer all the questions separately on a blog. And this, of course, will be posted on YouTube after so that people can go back and watch it. So if everyone can just bear with us another couple of minutes and then we'll get started here.
And Rachel, just verifying my screen sharing is working, and when I switch between slides, looks good.
Looks great.
Okay, perfect.
Good to go.
Okay, let's go ahead and get started here, guys. I'm Dr. Max Seiter, the newest addition over at VSON Orthopaedics. I'm sports medicine trained, did my fellowship over at Stedman, and was lucky to be able to stay up here in the Vail Valley in Summit County. I specialize specifically in complex shoulder, hip, and knee surgery, also treat some elbows as well. Today we're going to be talking about shoulder casualties of the mountain. There are a lot of knee injuries, well known in skiers, and a lot of wrist injuries, well known in snowboarders, but shoulder injuries are close second in each discipline here. Shoulder injuries, again, very common in both skiers and snowboarders. You yourself probably had a shoulder injury. You probably know somebody who has from being up on the mountain before. Normally the mechanism is a direct blow to the shoulder, so falling directly onto the shoulder and having all the force come up through the shoulder, or actually falling on an outstretched hand, which normally results in a dislocated joint, but can result in a fracture or other injury there. Of course, these injuries are more common in beginners. We've got a lot of research into this topic. If you have rental skis, you're more likely to have a shoulder injury, that sort of stuff. But also common in people who are very familiar with the mountain and very good skiers, generally doing maybe a little more risky stuff, skiing some bumps, skiing at high speeds, or going out in the terrain park. So today we'll be focusing on really the most common injuries, which are fractures of the clavicle or the humerus, AC joint separations. The AC joint is the joint in between the clavicle, which is the collarbone, and the shoulder blade, which is out laterally from the clavicle. Shoulder dislocations, probably the most common complaint actually, and soft tissue injury, which is normally accompanies a shoulder dislocation, but can actually happen on its own. Rotator cuff tears, labral tears, or bicipital pathology, which normally accompany either a rotator cuff or a labral tear. So starting up here with fractures, the most common fracture is fracture of the clavicle, and the humerus kind of follows far behind, but is not uncommon. Scapula and glenoid fractures are more uncommon, and we'll just briefly touch on those. Here we've got a little picture of the shoulder girdle here. The clavicle is the collarbone. You can see the acromioclavicular joint, which is the AC joint between the collarbone and the shoulder blade. And then the scapula actually composes a couple different bony processes, which are the glenoid, which is the cup for the shoulder, the acromion, which articulates with the collarbone up there, and then the coracoid, which isn't labeled on this. The humerus there is, of course, the arm bone, and lots of good orthopedic jokes about how fractures of the humerus aren't so humorous. Over on the left, you see these guys recommending that you call them if you have a broken bone. I recommend you call your orthopedic surgeon first. Clavicle fractures, very common in skiers and snowboarders. Summer sports as well, mountain biking, it's probably the most common injury if you head over the handlebars. These are generally due to a direct blow, fall onto the shoulder, or sometimes like a tree impacting directly over the clavicle. As with most fractures, our decision to recommend surgery or to recommend non-operative treatment is based off the displacement of the fracture, what that means is how far apart the fracture ends are, and breaking it down to kind of in layman's terms is most people say, oh, I have a broken bone versus a fracture. We call everything fractures, and then we say they're displaced or non-displaced. So non-displaced fractures are generally treated non-operatively. Throughout my training, the real tenet of a clavicle fracture was if both ends of the bone are in the same room, it's going to heal. But the question is not, is it going to heal, but in what position will it heal in? So if a displaced fracture is treated non-operatively, this generally results in something called a malunion, where the bone heals in a non-anatomic position and affects the ultimate function of the shoulder joint itself. That the clavicle at that point is no longer the problem, it's the function of the shoulder joint. ORIF means open reduction internal fixation. That just means going in and fixing the fracture with a plate and screws. So that reduces the risk of non-union, meaning a non-healing fracture, or malunion, a fracture healing in the inappropriate position. The real indications for healing this fracture are faster healing, faster return to function. In general, anecdotally, I'll fix a fracture, clavicle fracture, and see a patient back in 2 weeks, and they're generally pretty happy about it because they're really doing quite well compared to how they would if the two bones are floating in space. Outcome in a displaced fracture, we believe it results in greater power in the shoulder, increased shoulder function, and less pain. Tony Romo, the Cowboys quarterback, had about 4 clavicle surgeries. The reason why he had that done is he needs power in that shoulder. Like many people up here, he's going to go back to playing sports. And reason to fix it is get him back earlier and retain that function in the shoulder. So clavicle fractures here, I've shown you a little bit of our grading system. This is really specific to me as your treating orthopedist, but just showing that not all fractures are the same, that when we're looking at a distal clavicle fracture, which is more lateral, closer to the end of the bone, that we're concerned about actually the competency of the ligaments that attach the bone down to the scapula, which is the coracoid process there. If that is disrupted, we know it's an unstable fracture. It's not going to do very hot without operative treatment. So that's something we recommend surgery for. And then down on these radiographs down here, you can see a comminuted fracture, which just means a fracture with multiple parts, small fragments, that's been treated with a plate and screws and is well anatomically reduced, and that should go on to a uneventful union with a good restoration of shoulder function. Most clavicle fractures, rather than being at the end of the fracture, are in the mid shaft or the middle of the clavicle. But the same principles guide treatment here, that a fracture that is way away from where it should be living is not going to heal up and do well. So just like in your vehicle, the clavicle is a strut. It allows for the power generation through the shoulder. After fixing a clavicle fracture, they have a high rate of union, so healing, quick return to function. Hardware removal is common. About 50% of patients end up wanting their plate removed. It may bother you when you're wearing a backpack, that sort of thing, just rubbing over the plate. And then, as with all surgeries, when we're making a cut in the skin, there's a little numbness around the skin incision, but hardware irritation and the skin numbness are really the big complications, if you want to call them that, of having a clavicle fracture fixed. The humerus is, of course, the arm bone, and these fractures are more common as we age, and this is due to what's called osteopenia. You may have heard it as osteoporosis. It's loss of the mineralization of the bone and results in greater fragility. Anatomic reduction, meaning getting everything back into the position where it belongs, is very important, particularly of that cartilaginous surface, the two portions of the bone which articulate together between the humerus and the cup, which is the glenoid. The decision to fix these is based on the number of fracture fragments and the position of these fragments. And this is due to the fact that the rotator cuff and other soft tissue abundantly attaches around the near the humeral head there. So if there are fragments that are way out in space, that represents essentially like a really big rotator cuff tear, and that needs to be brought back down to where it belongs to restore the function of the shoulder once that fracture is healed up. So with a fracture, a humerus fracture that hasn't displaced, meaning it's not out of place, we can treat that either with a cuff and collar or a Sarmiento brace. Generally, though, I hedge towards recommending fixation because these do take a long time to heal up when they're treated non-operatively. Below the pictures of these braces, you can see a couple pictures of our fixation options. The preferred option is option A, which is fixing the fracture with a plate and screws, getting the fracture to heal and maintaining your anatomy. B is called percutaneous pinning. You may be able to pick up how that does not look very anatomic. And in general, we've gone away from percutaneous pinning because that construct tends not to hold up too well. If the fracture is a terrible fracture, and if you're a little bit older, we may talk about just going straight into a joint replacement. Figure C shows what's called a Hemi Arthroplasty. So that's replacing just the humeral head. And essentially the fracture just is cut out, and we go ahead and replace the fractured fragments with metal. And there's some cement down there to fix that in place. D is called a reverse total shoulder arthroplasty. This is reserved for the worst of our fractures or if the bone quality is very poor. And in these cases, this allows for the implant to substitute for the function of the rotator cuff. So it's a great option if there's no other options. So outcomes are hugely variable with humerus fractures. It really depends on the characteristics of the fracture. Up in the top left, you can see somebody who has just dusted their humerus, and that results in, generally not a great outcome, but the person who took care of this really did a phenomenal job of getting that back together, which is the preferred method of treatment there. But if, say, somebody has a humerus fracture, just thinks it's a bump and a scrape, and does not come in, now over on the right, you can see kind of our options there. That has gone on to a malunion, meaning all the fracture fragments are healed in what is really a terrible position. The options there are excising the malunion and then going ahead and placing either Hemi Arthroplasty, total shoulder arthroplasty, which are very similar, or the reverse. And in this case, the surgeons performed a reverse on that shoulder. Age, as in most decisions, does play a decision. The treatment algorithm that we don't like putting artificial joints in young people, worried about them wearing out. So in general, we always try to preserve bone and preserve the native anatomy. But if you're older and that's not possible, then usually replacement is the best option. And here I've just featured the anatomic total shoulder arthroplasty and the reverse total shoulder arthroplasty. The reverse places the ball on what used to be the cup side and allows the deltoid to work as the rotator cuff used to. Anatomic, we attempt to restore the anatomy. Scapular and glenoid fractures, we're just going to quickly touch on these here. Scapular body fractures are very rare. They're very high energy injuries, and normally that's the least of a patient's concerns if they do actually have a scapular fracture, because normally there's injuries to the lungs, the brain, etc. That these are really high energy injuries. Usually they do heal well. There's a copious blood supply and a lot of soft tissue attachment to the scapula. So generally these don't need to be operated on. As to the glenoid, this is actually kind of entering more into the shoulder dislocation portion of the talk, which I'll get to here in a little bit. But glenoid fractures normally accompany a shoulder dislocation. It's essentially like knocking off a part of a golf tee that results in the golf ball not being able to stay on the tee because you only have half a tee there. As with any fracture through the joint surface, there's a risk for rapid progression of arthritis because when the joint surface isn't concentric, it causes abnormal wear on the joint surface and causes that beautiful cartilage to be rubbed off. AC joint injuries, so very common injury, not only in skiers and snowboarders, but I imagine there's some hockey players out there, and this is actually the most common injury in a hockey player, but very common in skiers and snowboarders. This is probably the most common injury from a direct blow to the shoulder. Results in the clavicle popping up on the joint there. As you can see, this patient's right clavicle has dislocated upward. And again, as with almost all things orthopedic, our treatment is dictated by how far out of position that clavicle is versus its normal native position. Vast majority of these injuries actually do very well with non-operative treatment. Outcomes related to that are cosmetic deformity, again, as you can see up in the top right, but generally a return to full strength, full power, normal function, and painless function. However, if non-operative treatment does not work out, or if the clavicle is really displaced, then we consider doing something called an acromioclavicular and coricoclavicular reconstruction. And what that is reconstructing the two ligaments that you can see coming up with the red arrow next to them in the type 2 photo right there. That when you have an AC separation and the clavicle pops up, those ligaments have been disrupted. They will scar down, but without surgery, the clavicle will not scar down back into its native position. Surgery that I perform for this is called a reconstruction of the AC joint, and use something, a high strength suture between the coracoid there. If you look in the bottom right, that's my favorite construct for this. High strength suture that goes between the clavicle and the coracoid and pulls the clavicle down onto the coracoid. Then wrap around some allograft, which is cadaveric tissue, in order to provide some collagen for that ligament to reconstruct. Generally, the outcomes of this surgery are very good. But again, most patients do pretty well with non-operative treatment. And the kind of gray zone is called a type 3 injury. It's when clavicle's pretty popped up, but not insanely popped up. And that's when we talk about, well, what are your goals? How quick do you want to get back to what you're doing? Because you actually get back quicker with no surgery for this condition, since it takes a while for that graft to heal in place. A shoulder dislocation. So again, this is very common, not just in skiing and snowboarding, but in all sports. Personally, I've had surgery for this condition before. My shoulder's great afterwards, whereas I used to dislocate in my sleep, etc. Not too fun. But shoulder dislocation is always associated with a soft tissue injury, whether it's the labrum, which is normally the soft tissue injury in a young patient, as well as the joint capsule, or whether it's the rotator cuff, which as we age, that rotator cuff attachment is a little more tenuous, a little more at risk. So about 95% of shoulder dislocations are out the front, they're anterior, although posterior dislocations can be seen. Classically, it's an electrocution type event, but a big force going up through the elbow and out the back can result in a posterior dislocation. So the labrum, you can see down in our bottom right photo here, it is a fibrocartilaginous structure, and what that means is it's just a soft tissue structure that wraps around the bone. It increases the stability of the shoulder and decreases the amount of force that the cartilage sees within the shoulder. Also increases the amount of contact area for that cartilage and joint surface, which is important to prevent abnormal wear of the cartilage. The position of instability for an anterior dislocation, you can see in the top right, is called abduction external rotation. What that is if the arm is 90 degrees up and then the arm is twisted backwards, like you're trying to reach behind your head, kind of like you're trying to comb your hair, is the real at-risk position for a shoulder dislocation. Although shoulder dislocations can happen with a fall in many positions onto an outstretched hand. Age and other associated injuries are really important when deciding how to treat these. The major concern when I see a shoulder dislocation is the risk for any recurrent instability, meaning any further dislocations after the first event. Recurrent instability leads to irreparable damage within the shoulder. The real concern with repeat dislocations is damage to the cartilage. Cartilage can't take a joke, and once cartilage is injured, it does not repair itself. Preventing any further damage to the cartilage beyond the sentinel event is quite important. Furthermore, with repeat dislocations, the soft tissue becomes decreases in quality, essentially, that the labrum may actually degenerate to the point that it's not really able to be repaired, and the capsule becomes very stretched out, the joint capsule, which leads to further instability events. And then the most dreaded complication really of repeat shoulder dislocations is bone loss, that this can be a really difficult problem to fix. And we do have salvage procedures available for this, but ideally nobody needs a salvage procedure, and you're able to treat these before anybody progresses to that point. In a couple of the figures here, you can see what we call a labral tear is a Bankart lesion. It's named for a well-known orthopedic surgeon decades ago. The labrum peels off of the glenoid, which is the golf tee, the bone. And if you look in the top right where that arrow is, you can see a little triangle floating in space out there. That's a displaced labrum there that is just begging to be fixed. The bottom picture is a sad picture. This is somebody who has had multiple instability events, and if you can appreciate how that golf tee is no longer concentric, it's really has some very abnormal wear, and it's difficult to recognize actually as a glenoid. And then the humeral head is no longer circular. It kind of looks like a little Pac-Man. And that dent in the back is caused from repeated dislocations and what's called an impaction fracture. It's just like punching into a ball of styrofoam that there's a dent in there that will never pop back out. So this becomes a very difficult problem to fix, and does not have the same outcomes as a patient who has been treated earlier without as many dislocation events. The risks for recurrent instability are important to discuss with any patient who comes into my clinic. I generally, in a younger patient, will recommend operative treatment for a first-time dislocation, because the odds are you're going to dislocate again and cause a lot more damage around that shoulder, especially up here where people are really wanting to get back to the things they love to do, skiing, snowboarding, mountain biking, anything else where the shoulder is at risk. The risks for recurrent instability are young age. Obviously, as we're younger, we are generally more exposed to sports. So this is a dogma that doesn't really hold true here, because a lot of people are still extremely active, even into their 70s and 80s here, which is abnormal compared to most populations. So young age, I say with a caveat, because it's really exposure to those risky sports that leads to these. If you're going to jump off a roof, you have a risk of dislocating your shoulder. But also males are more frequently involved in contact sports such as football, etc., and may have a repeat dislocation from that sort of event. And then high demand sport participation, I'd already kind of touched on this, that's probably the biggest risk factor there, that as you are involved in more sports that put the shoulder at risk, you're at risk for another dislocation, especially when you've had an initial event. That although the shoulder may feel great after a couple weeks in a sling, and you go back to doing everything normally, the shoulder is not the same. The labrum has been torn, the capsule has been stretched. So there is some inherent proclivity to dislocate, despite the fact that the shoulder feels great. And, again, anecdotally, I went through this myself through trial and error, and when I was playing college sports, and found out that eventually my shoulder was not stable enough, and it ended my college sport career. So these things are important to know, and important to have somebody take a look at and address if you are having some instability issues. Number of dislocations is of course associated with more recurrent instability. As we dislocate more, we're again at risk for further soft tissue injury, bony loss, and bone loss. Golf tee analogy right there. So if the bone's not there, that's the most important stabilizing factor in the shoulder, that shoulder is not going to be stable if you have bone loss. Hyperlaxity. Probably know some double jointed individuals, maybe you yourself. These people are at a higher risk for dislocations. You're stretchy, you're kind of like Gumby, and those joints do come out. There's certain congenital conditions where dislocations are very common, but even in what we call benign hyperlaxity, which is just an average person who has some stretchy joints, those people are at a higher risk for a dislocation. And then once they've had a dislocation, a much higher risk for having a recurrent dislocation. So operative treatment, there's a lot of different options, and hopefully we're getting to the shoulder before some of the more invasive procedures are required. The first and foremost is treating everything through the arthroscope. So treating it minimally invasively and repairing the labrum back down to the glenoid, which is the bone. That's done with something called a suture anchor. It's a very high strength piece of plastic loaded with sutures that we place into the bone, and then allows us to place sutures around the labrum or any other area in the body. We use them for all kinds of reattachment of tendons and soft tissue, and allows us to put that back into an anatomic position and restore the stability of the shoulder. Normally, with that, we'll take a little bite of the capsule and tighten up the capsule, which has been stretched. And so we're treating what we call a patchless capsule in that scenario. In somebody who may be more high risk or have had a couple more dislocations or have a little worse pathology at the time that they come into the clinic, we consider doing a open Bankart, which is a open repair of the labrum and a capsular shift. It's the same thing that we do underneath the arthroscope minimally invasively, but it leads to a little more tightness in the shoulder. Downsides of this are a little bit more stiffness in the long term, and there may be a slightly higher risk of arthritis. Also, getting down in the open procedure, we have to violate one of the rotator cuff muscles, which we do repair, but anytime you cut a rotator cuff muscle and you have to repair it, there's a risk that it doesn't heal. So always better to have this addressed earlier on before a more invasive procedure is needed. Then the Latarjet is a great procedure for the patient who needs it. Not a great thing to need the procedure though. So this is for somebody who has failed soft tissue stabilization, meaning the labral repair or capsular shift, or somebody that has glenoid bone loss. So the golf tee has been rubbed away and we gotta build that golf tee back up. For that, we take a portion of the scapula, the coracoid, which you can see in quite nicely in figure A and B. It's the small little finger-like prominence that's over that rotator cuff muscle. We cut that off and then graft it onto the glenoid there, which restores the bony anatomy of the glenoid and has an additional stabilizing component that a portion of your biceps and another muscle called the coracobrachialis attached to the coracoid. This creates a soft tissue sling around the shoulder so that when you go up into that position like you're throwing a baseball, it's actually that sling stabilizes the humeral head within the joint and prevents any shift out the front of the joint anteriorly, which is again where most dislocations do occur. There's another procedure called a replisage. This is to treat that large dent in the back of the humeral head. Generally, personally, I'm not a fan of this procedure. Somebody who needs that generally also needs a Latarjet, and the replisage really makes people stiff. So if it's avoidable, it's something I like to avoid because you're gonna lose motion. And although the most important thing is to have a stable shoulder, if it's something we can avoid, it's something I like to avoid because ultimately you want the best shoulder function. Most important is stability, but shoulder function is quite important. You know, you want to be able to comb your hair, put on your belt, etc. Rotator cuff repair. So again, this is more common in a elderly patient, and I'll get to rotator cuff repair here in a second. If we're doing a rotator cuff repair, normally we're going to go ahead and do a biceps tenodesis at the same time. Biceps is where you think your biceps normally is, just like, you know, your little Popeye muscle there. But the biceps tendon actually runs in through the shoulder joint. It takes a very tortuous angle there and is at high risk, and it sits right next to the rotator cuff. So normally if there's a rotator cuff injury, there's a biceps tendon injury too. So outcomes are really associated with the preoperative risk factors. You know, again, how many dislocations have you had? What's the bone loss situation? What's the soft tissue situation? More dislocations equivalates to worse outcomes. This has been well proven in the data. And if you have a lot of dislocations, you're at risk for very quick progression to shoulder arthritis. I treat a lot of shoulder arthritis. You know, we've got great procedures for it, but it's better to avoid having an arthritic shoulder if you can. Delayed treatment, it generally equates to more dislocations and worse outcomes. And then again, our more invasive procedures, these are salvage procedures. These are not cure-alls. It's not something you want to have done to your shoulder. It's, you know, it doesn't make you the $6 million man or whatever that if we can avoid doing something that is more complex to your shoulder, that's a better scenario because it means your issue wasn't as bad to start out with. The goal is restoring the stability of the shoulder. That's the paramount, most important thing. But treating the soft tissue injuries and preventing arthritis, which is wear of the cartilage. So in a rotator cuff tear, this can happen with a shoulder dislocation, but can actually happen really, you know, if you skin a lot, if you're a big cross-country skier, you're using that shoulder a lot, and you can have an attritional tear of the shoulder, but also a direct fall onto the shoulder. Sometimes you can avulse that rotator cuff tendon right off where it lives out there on the outside of the shoulder. Pain may awaken a patient from sleep with this. It's normally pain down the outside of the shoulder, down the course of the deltoid. These are generally associated with weakness. You may notice some weakness picking up a milk jug or some weakness when you're externally rotating your arm. And then when a rotator cuff tear is acute, so if you have a fall and all of a sudden you have a lot of pain, feeling weak, those are things that we want to fix immediately because that tendon will retract, become more difficult to repair, and possibly not repairable, which is a bad scenario. The spectrum of pathology here, again, this can be an attritional injury, so can start out with just some inflammation of the tendon, then progress to a partial thickness tear. Ultimately, a full thickness tear is a complete detachment of the tendon. And then an irreparable tear is one that has retracted so far that we cannot get that tendon back over to where it belongs. And these may or may not be accompanied by arthritis. So first line of treatment for a chronic kind of attritional tear that may not be full thickness is conservative management. Physical therapy is wonderful for this. Anti-inflammatories are part of my mainstay of treatment. And then plus or minus injections, which is normally a steroid or a biologic injection like PRP or bone marrow aspirate. These may help induce some healing, although our data is still coming out on that. And there's a lot of discourse within the orthopedic field as to the role of biologics. I'm a believer, but I don't put too much false hope into them. It's not going to fix a mechanical problem, but it may help a partially torn tendon heal. Surgical treatment for these. Normally, if you have a fully detached tendon, I'm going to recommend surgery for you. It's a shared decision making, so I never tell somebody you absolutely need surgery. I'd say I'd recommend fixing this because if we don't now, this may not ultimately be fixable, depending on the exact characteristics of the tear. In tendons that are not fixable, we have an option called a superior capsular reconstruction. This is putting cadaveric graft where the tendon used to live. And this is a stopgap that almost all these patients who have a superior capsular reconstruction will ultimately go on to need a shoulder replacement. But the goal is, you know, if you're 50 years old, you really don't want to reverse total shoulder, ideally. If it's the only option, it's the only option. But if the joint itself still looks good, meaning if there's no arthritis and if it's just a huge rotator cuff tear that we can't fix, then this is the best option. And outcomes have been pretty good with this procedure. But again, it's a salvage procedure, so it's never going to be the same thing as your native anatomy or a repaired rotator cuff tendon. Reverse total shoulder arthroplasty is a true blessing of a procedure. I showed that implant earlier. It's reversing the ball onto the cup side of the shoulder. And this allows the patient with a reverse shoulder to actively get that arm up above their head, go back to playing some sports, etc. It's really a great procedure. It wasn't available about 15 years ago. And I wouldn't say it's a panacea, but it is a really good option for an issue that we used to not really have a good treatment option for. Biceps tendon here. So if you look over on your left, you can see that biceps tendon taking almost a 90-degree angle into the shoulder. That's a very at-risk tendon right there. And if you were to thumb your biceps tendon over the front of your shoulder right now, you can kind of feel it in between the groove between the pec muscle and the deltoid muscle. You probably feel you may be even a little tender over that right now. It's very common to have biceps tendonitis. Pain from the biceps generally associated with motion. It's in the front of the shoulder, and in the exam room, the most consistent finding is that bowstringing that tendon causes a large amount of pain. It's very similar to the rotator cuff, that there's a spectrum of pathology ranging from inflammation to complete tears. And the way that the biceps tendon is treated is, again, if it's just a little wear and tear and we're trying to see if we can avoid surgery, is physical therapy, injections into the sheath around the tendon, or injections into the shoulder itself. That biceps tendon, again, does live in the shoulder. And then anti-inflammatories, as always, are a good adjunct to orthopedic inflammation conditions. Surgical treatment, the biceps tendon can be cut and you can allow it to drop. That's not my preference. Although it's an acceptable treatment, there's a lot of data showing that if you just have a tenotomy without having the biceps reattached, tenotomy means cutting the tendon, that may result in cramping of the biceps with repetitive motions. Little known fact about the biceps, the main supinator of the wrist. So if you're right-handed and you're screwing in a screw, that's what supination of the wrist is. So if you're doing a lot of things that require repetitive supination, that bicep will cramp, fatigue, and it's better to avoid that. When we have, you're right there, you've got a great treatment for it, which is the Biceps Tenodesis. And with that, we do the same thing as the tenotomy. We cut the biceps tendon, we take out the diseased portion of the tendon, and then over on the right picture here, you can see how the biceps tendon has been reattached into the top of the humerus bone there, which re-approximates the length and functional unit of that biceps muscle and tendon, and allows it to function as it did before. That tortuous portion of the biceps tendon is kind of vestigial, that taking it out, really, there's no functional implications. And if it's disease, it just results in improvement in your condition. As always, the biceps tendon is normally associated although it can be in isolation, normally there's something else going on when you have a biceps tendon injury, whether it's an injury to the front rotator cuff muscle, the subscapularis, or whether it's an injury to the kind of proper rotator cuff, which are the ones over the top, the infra and supraspinatus, or whether it's an injury to the labrum, which is where the biceps attaches. But in general, especially in a traumatic scenario, biceps tendon is accompanied by an injury of one of those two, and we're going to go ahead and fix them up at the same time. So just a brief overview on the recovery after a rotator cuff or a labral repair. The sling depends on the size of the tear and what was done intraoperatively, but good baseline is probably about 6 weeks in a sling. During that time period, normally working on some passive range of motion. So working with somebody like Josh, our physical therapist, who is working to just keep some of that motion in the shoulder. We don't want to stress it too hard because we don't want to stress the repair. And then doing a little isometric strengthening, just keeping those muscles awake while you're locked down in a sling, trying to prevent too much atrophy. At 6 weeks, we really start to take the governor off a little bit and start working on active range of motion, which is motion powered by your own muscles, and lifting a fair amount of those restrictions, doing some light strengthening and endurance work. At 3 months, I expect a full range of motion, whether it's the labrum or the rotator cuff. Not everybody has it by then, but ideally we're definitely back by then, and should be returning to most activities. Not yet cleared to go out and do high risk things, but getting back to a normal life, and doing some of progressing in the level of exercises that you're doing, strengthening for power. And at 6 months, I expect a full recovery, return to high level sporting activity, maybe even a little before on that, but really dependent, every patient's different. And I'm a big fan of actually doing therapy based on, rather than arbitrary time milestones that, we know certain injuries take a certain amount of time to heal, like a tendon to a bone, but beyond the 3 month time period when we expect all that to be healed up, every patient's different. So looking at you as an individual rather than just looking at a sheet of paper and saying this is where we should be and this is what we should be doing next. So I think probably the most important thing I can tell you from this presentation here is wear a helmet. That I'm an orthopedic surgeon. Injuries will happen. That's why we're here. That's why we have such wonderful orthopedic care in this area. It's probably the best orthopedic care in the world with the concentration of surgeons that we have here. And something that we can't fix is a brain injury. So wear a helmet if you're out there. And try not to be featured in a YouTube compilation. Just stay safe out there, guys. So thank you for your attention, and I will turn it over to Josh here.
Thanks, Dr. Seiter. Let's see, I'll share my screen now. So I just want to say a little bit, just to kind of add on to what Dr. Seiter was saying. As physical therapists, we see a lot of, we see them, sometimes before surgery, sometimes afterwards. Ideally, our job is to kind of prevent you guys from having surgery. But, sometimes we can't do that. And so then once you have surgery, we want to get you back to everything that you want to get back to. I think pretty much every therapist here, skis, snowboards, bikes, we're all here for the same reason. So we have the same goals. We want to get you back. And we want to get you back as quick as possible, but as safe as possible. So yeah, we work at Avalanche Physical Therapy. I'm at the Recurrent Rec Center. We're still fully open. The rec center is also open at a limited capacity, but we still have access to the rec center. So, as you progress with your treatment, you can kind of go into, if we need to more weightlifting. I do aquatic therapy on Thursday mornings. So we do have, still have access. It's been a great relationship with the rec center. We also have locations in Frisco, which is connected to the hospital, and the VSO office, and then also in Silverthorne as well. Just a little bit about me. I'm Josh Jones. I got my doctorate of physical therapy from Old Dominion University a while back now. Orthopedic certified specialist and a champion performance specialist. I've been lucky enough to work with the X Games with the United Kingdom as their physiotherapist, and then worked through tour and a few other ski and snowboard competitions. Level 2 dry needling certified, we'll get into that. And then, like I said earlier, we're getting into some aquatic therapy as well. So Dr. Seiter talked about this before. We got to get the range of motion back. A lot of people have heard about frozen shoulders. We definitely want to avoid this. The shoulder tends to want to freeze up. So we're here to help protect that and then also protect the repair that Dr. Seiter has performed. So initially we're starting with passive range of motion, active assistive range of motion where you're getting a little help, and then active range of motion on your own. And then we'll progress to strength, coordination. And then there's a few things that we can do also to help take away some of the pain and improve function, which is taping and then functional dry needling as well. So initially getting into, that doesn't look very good. Getting into passive range of motion and active assistive range of motion. So Dr. Seiter and other doctors will give us kind of things to not do. So at this stage, don't go this far, don't go this far. And so, shoulder recovery can sometimes be a little boring initially because we're used to doing so much and pushing so much, but you got to let things heal. So we take you, the goal is you got level 1, we want to get you through level 1 so that when Dr. Seiter says, all right, you're cleared for level 2, you're ready for level 2. And so we can just keep pushing you, and then you get back as quickly as possible and as safely as possible. That's going to do it for everyone, I guess. And then we're going to get into strength and coordination. So the shoulder is a little different joint. There's so much motion, and he talked a lot about the golf ball and the tee. So there's a lot of mobility, but not a lot of stability. So you don't just want pure strength. You also need to work your scapulohumeral rhythm, which in this picture shows a roll slide mechanism. So basically you're trying to keep good congruency of your shoulder joint with the humerus and the glenoid. And so we have to help with do that before we can get really big strength, and also rhythmic stability as well. Functional dry needling can assist in this. Sometimes muscles will tend to shut down. So we can use dry needles, which is different than acupuncture, to get into the muscles that are tight or sometimes, turned off. And that'll help increase blood flow to the area, which is always good, but it also helps release the trigger points or the top band of tissue. There's been research that's shown that if you get the biggest trigger point, the other ones will start to release as well. And then we also like to hook them up to electrical stimulation. So you might have had this in the past with some pads that go onto like your back or your leg, shoulder. We actually just connect the same machine to the needles. So it's a little more specific. It can help turn on those muscles again so they're firing on all cylinders. And that helps you get back as quick as possible. And then the last one we're going to do, if this thing will work, technical difficulties, is taping as well. So I guess the slide's not coming up on here, but for taping, especially with AC joints and clavicles, tape just to give a little more support. Dislocated shoulders, we can also tape to give a little more support. A lot of it's going to be more tactile cueing, so you kind of know where your shoulder is in space a little better so you can help protect it. But with AC joints, we'll actually push pretty hard down on the clavicle to kind of help push it back down. And so when it heals a little closer to each other, but you'll still have a bump without surgery, almost guaranteed. But I just want to go over a few quick things of what we can do to kind of help get you back on the slopes, whether it's surgery or hopefully you can avoid surgery as well. But yeah, thank you so much for your time. And then, we'll leave it up to some questions if anyone has any.
So if anyone has any questions, you can feel free to type them in the chat box or the Q&A box. And if no one has any questions, that's fine. You can feel free to visit us on our website, vsortho.com, or you can email valesummitorthopaedics@gmail.com, and you all should have that email in your inbox from when you signed up for the webinar. We'll be happy to answer any questions at a later time.
I think we've got somebody raising their hand down there, Rachel.
I see the raised hand. I'm not sure if there's a question. Anybody has a question, would you mind just typing it into the chat box so we can see it? I'm not sure if that participant had a question, but I don't see one. I think we might be all set on the questions.
Okay, well, thanks for tuning in, guys. Always a pleasure to do these webinars. Nice to be able to do some form of community outreach here in what's a difficult time for everybody.
Yeah, thanks so much. Appreciate your tuning in.
Thanks, everyone. And please be on the lookout for more of these webinars. We try and do them at least a couple
Hold on.
months. So.
There's one question.
Oh, here we go. So is massage contraindicated for a dislocated shoulder?
So I would say not at all. But I would say, you know, if you've had a shoulder dislocation, you should see myself or another orthopedist just so you can get a baseline of what's going on. Because in general, I'm going to go ahead and recommend grabbing an MRI. Not always necessary, but I think whether it's sending you straight over to PT like with Josh, really it's very important to get the muscles back, the shoulder strong again, because not only is there static stability in the shoulder, which is the bone and the soft tissue restraints, but Josh can tell you even better than I can that getting that muscle strong around the shoulder is really critical to the stability of the shoulder, and not even just preventing a repeat dislocation, but preventing what's called micro instability, but little subluxations of the shoulder, which ding up the cartilage and cause a little damage within the shoulder.
Yeah, I would agree. Also, you know, massage therapists around here are very good, and just the main thing is to let them know what's going on, so that they understand that you recently dislocated your shoulder, so they're aware. And then, you know, sometimes it's great to work together as a team as well.
Awesome. And then we got a couple questions from Colette. She said, I had a fall skiing about 5 years ago. I honestly believe it's a rotator cuff injury. It hurt for about a month and then got better. Now it's back up and hurting. And then she follows up with, I know I need to get this assessed, but have I waited too long?
No, in general, not. That this is a very common course for a rotator cuff injury. You probably had a small tear at the initial fall, which is very painful. And once that inflammation cools down and from the acute injury kind of settles down, then you're left with a tear there that will eventually propagate over time. And that's just because the way that rotator cuff inserts onto the head, it'll gradually start to peel off with repeated contractions. You know, you're doing millions of contractions of your shoulder muscles over the course of a year, and that can just gradually pull those fibers away, that they've been disrupted. The integrity of the attachment of the muscle there is no longer what it once was, and then this can result in a larger tear, which becomes symptomatic. We've got, actually, there was a very beautiful study done probably about 6 years ago looking at small tears and how do they progress to large tears. And we know that the front edge of the rotator cuff is at risk for that form of progression. And about 50% of patients with a small tear will progress to having a large symptomatic tear within 2 years. And that's even in patients that are not symptomatic from their tear at the time they're evaluated.
Doesn't look like we have any, or we might have one more question. 1 second. Oh, she said, thanks for the info. She also says, I also hear a click occasionally and it hurts when it happens. What might that be?
That may be a little clicking of the labrum, that as we age, labral tears are not only caused by trauma, but can just be caused by wear and tear and degeneration. So sometimes there's a small little loose body within the joint, whether that's a piece of soft tissue floating around or a little piece of cartilage that is clicking within and out of the joint. Or sometimes it's actually the labrum kind of flipping in and out of the joint in between the articulation between that golf ball and that golf tee and rubbing in and out. I normally don't get too worked up about painless clicking, but if it's painful, then that's something to worry about.
All right. Well, I think, let me see if there's more. She also wanted to ask if those two injuries are easily fixed.
Generally, yes. You know, it like impossible to say without seeing you and without getting some higher level imaging, normally an MRI on the shoulder. But in general, yes, that's bread and butter sports medicine. That's stuff I do all day long. And you know, although I've kind of read the riot act about retracted tendons and them not being repairable, normally a rotator cuff tendon is repairable, especially if it's the first go.
And for the individual that asked that, as well as for anyone else still on the webinar, if you would like us to reach out to you regarding any injuries or things you might want looked at, we can certainly have Dr. Seiter's team reach out to you. So please feel free to let us know in the chat box and provide your email, or just shoot over an email to vailsummitorthopedics@gmail.com. I think that's all the questions we have for now.
Oh, I see Clem's got one question there. The knee meniscus doesn't regrow. The knee meniscus can heal, but a meniscus tear and somebody who's meniscus deficient, which means the meniscus is gone, are two different conditions. Although meniscus generally is not going to heal up too much without surgery, it can actually be treated with physical therapy and may become asymptomatic. It's a little more detailed description than that, but not all meniscus tears need surgery, and they do have some propensity to heal. And with surgery, you know, that's our primary goal, is preserving the meniscus. I'm getting a call from the hospital here. I'm sorry. Hello, this is Max. Yeah.
Okay, well, I think that's all the questions that we have. So.
Perfect. Yeah, thank everyone. I appreciate it.
Yeah, everyone, just keep an eye out on your email. We'll be sending emails with more webinars you can sign up for. And feel free to visit our website at vsortho.com. All right, thanks so much, everyone, for your time, and we look forward to seeing you on the next one.